we've talked about induction, we're talking about consolidation, but clearly we know many patients can have a more difficult course and have more difficult disease. First, let's tackle those with primary refractory AML, particularly challenging group. But in terms of a non-clinical trial setting, and of course, if there's any group that really needs a clinical trial, I would argue it's certainly this very refractory group. But certainly it's very stubborn. I know sometimes what we've struggled as well, even people who failed studies, do we transplant them in aplasia? What have been some of the approaches that your centers have taken with this most difficult group?
Ruben, as you mentioned, the refractory patients they have very poor prognosis. In fact, we published a couple of years ago that patients who failed high-dose RSC induction, their median survival is only 3 months. So it's really horrible, bad. Now, that being said, if you have clinical trial, that would be great. So we will do it at my institution. We look for a donor immediately. So whenever somebody coming with AML, before we induce them, we have a donor. If they have a sibling, we have a donor identified, fine. If not, with the new techniques of transplant, haplotransplant seems to be really good and gaining momentum. So if you have somebody with refractory AML, we publish that the only way to save them is transplantation. It can give you a survival at 2 years of 25% instead of 3 months.
Yeah.
Okay. Therefore, I have somebody who's young, well-fit, get high-dose RSC, failed. My plan is to give them very suppressive chemotherapy, like at NDC, we use clofarabine, IDA, RSC, plus decitabine priming. And then we do not wait till they recover. I get day 21 bone marrow. If their blasts are low, which will hopefully most of the case will be, I will go for transplant. If they have a sibling, it's a sibling. If not, haplo. Any donor available, go for transplant and hope for the best. Because if you leave them otherwise, they're going to die. If you have a good trials, by all means. But at least that was so far been reported.
That's very helpful. Now, what about the relapse patient? A slightly different scenario. The patient is, had achieved their CR, they had their consolidation, they were, happy that the disease was in a remission, but now it's relapsed. So one, what are your different thoughts around that relapse patient, both in terms of time from the prior therapy, as well as other factors in terms of determining what to do next? Rami?
I think you mentioned the key point, Ruben, that basically the time of relapse is one of the most important. Like some would include that a relapse within the first 6 months is really a refractory AML. And what the studies have shown that the most predictable factor for a second remission is really the duration of first remission. So for those patients that their disease relapses after a year or 2 years, I think we have really decent chances to get the patients back into remission. Sometimes even the standard, if somebody relapses after a year or 2, you could go back to the 3+7 regimen itself. The patients that relapse earlier are really the challenge ones, and they almost could be like a refractory group. So it depends, obviously, even in that setting on the time of the relapse. The idea in those patients is to try to achieve a second remission if possible and take them to allogeneic stem cell transplant. And I think that's challenging, and that's always like back and forth between us and our colleagues in transplant. They want patients to be in complete response, while, as Ali mentioned, sometimes an approach is maybe you can take those patients at like at their nadir. I think you published nicely in patients with that, transform from MPN to AML. Those patients are almost impossible to get them in complete remission. I think you showed that the best outcome for those patients was to go at that time, but that's always a challenge. So when they relapse early, obviously if there's a clinical trial, we try to go for that. If not, I don't think there is a standard relapse regimen for AML. I think every institution uses a combination, whether it's MEC, FLAG, CLAG, they've never been compared head to head. But the idea is to try to get patients into second remission and take them to transplant. In the early relapses, the chances of that are really small. So there is definitely unmet need to improve that.
Now, Raf, one scenario in this mix is the patient who is relapsing. Let's say they have that potential donor, that is an option for them, but now they have the 8% blasts. So they're moving in that direction. And the question always comes up, do we reinduce them? Do we give them some sort of lower intensity cytoreduction, or we take them straight to transplant? With obviously the concern, if we undertreat them, then they'll have a higher risk of relapse on the back end of the transplant. What are your thoughts trying to decide between those sort of options?
Well, I already mentioned it earlier. I think the amount of time that you predict the transplant will take to get in place may determine your choice of therapy at that point. If you're ready to go and you've planned things ahead of time, it may be best to just go if you think your chance of actually reducing the patient isn't great. If you know it's going to be a while before that transplant's in place, I think it does make sense to try to cytoreduce them. Now, whether that actually helps, I don't know that it's entirely proven. We know that if patients can achieve a deeper remission or clear their blast, that they're likely to do better, but that just may be identifying those patients that are likely to do better regardless. So I'm not sure that you're obligated to treat right at that moment if you're ready to go to transplant.
Elias, what would be the approach, particularly with that delicate piece? You guys clearly must see a bunch of these folks back in that sort of same scenario. Cytoreduction before transplant or not? What are you?
As Rafael mentioned, if I have a donor ready, I may go for transplant and use my maintenance program afterward. But most of the time, we don't have a transplant happening. Rami mentioned in my institution where we do a lot of transplant, it won't happen before 6 weeks, sometimes 3 months.
Sure.
And that will be an opportunity to treat somebody. I may not go for intensive chemotherapy. I may like to go for something when I discuss maybe some innovative approaches, like ABT-199, something new, start to reduce them and go for transplantation whenever they're ready.